And you'll also have Dr. Kerr for 2 hours on Sunday morning. There, as you are aware, is a tremendous variability in the presentation of transverse myelitis. And one of the more important issues that everyone is interested in here is whether there are differences between adult cases of transverse myelitis and pediatric cases of transverse myelitis. We get children as young as 6 months old who get TM. And Dr. Pidcock is going to talk about pediatric transverse myelitis.
Good afternoon, and thank you for asking me to speak about pediatric transverse myelitis. I work at the Kennedy Krieger Institute here in Baltimore, and I work with Doug Kerr in the Transverse Myelitis Center. What I'd like to present today is information that we've been gathering on the children with transverse myelitis who have come through our center here in Baltimore. And what we're hoping to find out is, are there clues in terms of how they present and what some of their symptoms are that will help us decide better in terms of rehabilitation strategies. We're also going to present today some more specific information about the functional outcomes of children with transverse myelitis, primarily because this hasn't really been looked at very carefully in the past. So let's start with, what do we know about transverse myelitis in children? To start with, as many of you know, this is a very rare disorder. It occurs about 4.6 per million individuals per year in the United States have transverse myelitis, and it's estimated about 10 to 15% of those are under the age of 18 years of age. Clinical manifestations. This is something that with kids it's sometimes harder to come up with because they don't give you quite as good a history as adults. So the question is, do children present differently than adults with transverse myelitis? There's an issue out there about, do childhood immunizations constitute one of the predisposing factors for developing transverse myelitis? So that's an issue that we looked at in our analysis of this information. And finally, as I mentioned earlier, what are some of the functional outcomes in children with transverse myelitis? And what can we tell parents in terms of what to expect to change and and how long it will take to change, given the rehabilitation strategies that we have? Here's a slide that shows the various case series of reports about individuals with transverse myelitis. They started with this report by Dr. Payne in 1952 to 1929, and he reported the first case series of 25 individuals. Most of these series encompass a pretty long stretch of time, 24 years here, 20 years here. Dr. Knabush only reported 8 cases, which he'd collected over 4 years. Recently, there was a published article on kids by Dr. D. Fresnay. In 30 years, they collected about 24 patients. The Johns Hopkins Transverse Myelitis Center, in the course of about 4 years, has collected information on over 47 cases, and we're still going up. So I think this represents a fairly homogeneous collection of information collected over a short period of time, so we can look at intervention strategies and how they've affected the outcomes, rather than looking at an extended period of time where the way people think about transverse myelitis may have changed, or the interventions may have changed as medical developments occurred in other areas. So beginning in January of 2000, we started to enter patients into our clinical database. The definition that we used was based on the algorithm that Dr. Kerr just presented in the previous lecture. And we looked at the information from a retrospective manner, going through the charts, and then if there was information missing, we'd call up families and try to fill in the gaps. A total of 47 patients with acute onset of transverse myelitis at less than 18 years of age were analyzed. 89% of these cases, as Doug mentioned, were monophasic idiopathic cases. 2 were recurrent cases of transverse myelitis, and 4 cases had other diseases associated with the symptoms. This is a graph that shows the age of onset in our group, and it was interesting to see that there are basically 2 peaks. There's a very young peak here, which hasn't really been reported by other series, and then there's this peak in the early teenage years, which is consistent with other case series of individuals with pediatric transverse myelitis. The average age of onset was about 8.3 years, and this is also consistent with other reports, that if you average these 2 peaks up, then you get an age of about 8, but actually there was only 1 8-year-old patient in the series. Another thing that we looked at was there any seasonal trend to the presentation of pediatric transverse myelitis? And it did seem like the summer months were the most represented here, with 16 of the cases that we looked at. And this was actually reported in another case series by Dr. Dunn, where he felt that the presentation of TM was more common in the summer months. So it does raise the question, is there some reason for that? Is it related to some infectious etiology that might be more common in the summer versus one of the winter colds, for example? This is some information that we looked at regarding is there a link between the common childhood immunizations and transverse myelitis? And in our group, 28% reported a preceding immunization, 13 out of 47 cases, at an average of 14 plus or minus 2 days prior to the onset of symptoms. The immunizations that were reported were the DTP, polio, flu vaccine, measles, mumps, and rubella, and 1 case of smallpox vaccine. And all the vaccination records were confirmed. This is a lot different from other case series. For example, Dr. D. Fresnay, who published the most recent pediatric case series, only found 2 out of 24 cases with a history of a recent immunization. If you look at this slide here, one of the common trends, now these are three different case series. Dr. Payne early on in the 50s, Dr. D. Fresnay's published case series, which is also goes back about 30 years, and then the Johns Hopkins experience. It looks like a history of preceding respiratory illness occurs in at least 40% of the cases. In all 3 large case series, that was the most common identified preceding factor. But look at this bar here, the gold bar. Fresnay and Payne had immunizations or vaccinations at below 10%, and so far in our case series, it's over 20%. So my question is there something that's changed in the way that we give immunizations, or the practice of giving immunizations that might account for this? We're not sure, and we're still going to have to look at this data with more careful scrutiny. And one of the reasons is this slide here, because this is the currently recommended immunization scheduled by the American Academy of Pediatrics. And I put it up because these days kids are getting lots of different immunizations at lots of different times during childhood. So one of the questions that we're going to have to look at statistically is, just on random, what's a child's chances of having an immunization within a month or so of an onset of transverse myelitis, given the fact that under 5 years of age, they're being immunized fairly frequently. 2 other things that we looked at were the connections between illness and trauma and the onset. So in the case series that we're looking at now, in the 47 cases, 47% reported an antecedent illness, an average of 11 plus or minus 2 days before the onset of symptoms. In 8 cases, an immunization and an illness were reported together. And this question about does antecedent trauma relate to the onset of transverse myelitis? In the group that came to Baltimore to be evaluated by the team at the Transverse Myelitis Center, about 13% reported an antecedent trauma with an average of 8 days prior to the onset of the neurological symptoms. And it's interesting that some of the other case series don't really mention trauma as a possible etiologic factor. To review, and this also goes over what Dr. Kerr mentioned too, that the clinical findings that we associate with transverse myelitis, and it's true for kids as well as adults: sudden onset of rapid progressive weakness of the lower limbs, loss of sensation, loss of sphincter control. So here's Doug's motor, sensory, and autonomic pattern, pain, without signs of spinal cord compression. The difficulty for us pediatricians is that it's oftentimes hard to get this history of loss of motor function or sensory loss in the really young child, the children who are under, let's say, 2 or 3 years of age. And sometimes this is sloughed off as, well, they're having a bad day or they're not feeling well, and consequently the diagnosis gets delayed. Another way of looking at the presentation of transverse myelitis is the clinical course, and this touches upon what Doug mentioned in the previous lecture when he talked about what's the definition of acute onset, and is it different in kids? These time frames were presented by Dr. D. Fresnay in the recent article that he published, and he broke up pediatric transverse myelitis into 3 phases. An initial phase where you progress to your worst, 1 to 14 days. So this is slightly shorter than what Doug had mentioned for adults of being 1 to 21 days, with a mean progression to their absolute worst about 5 days. We did look at that in our group of patients, and the time to nadir or the worst symptoms before you stabilized was about 2 days. So kids, when they present with transverse myelitis, tend to go downhill to their lowest point, perhaps faster than adults do. The plateau phase is a phase where you are stable, not much changes, and there's no sign that you're getting better. And in this series, it was defined as 1 to 26 days with an average of 6 days. And then the recovery phase, where you can regain function. And it's our experience and that of others that this can occur for as much as 2 years following diagnosis. And I think with the recent information that we have about rehabilitation strategies and the amazing capacity of the central nervous system to respond to exercise and repetitive stimulation, that it goes on beyond 2 years. And I think this is, just to reinforce what Dr. Kerr said, a really exciting time in rehabilitation, because we're starting to find out that these therapies continue to give benefit to individuals. This is how we broke down the acute symptoms that presented to our group. Pain is 75%, weakness 89%, urinary dysfunction 85%, sensory loss in 91%. And then at their nadir, most of these children were bedbound or required assisted ventilation. So one possibility is that the group of patients that we're seeing through the Transverse Myelitis Center here at Hopkins represents the more involved group of individuals with transverse myelitis. So there might be a selection bias here. Sensory levels can be documented in almost all patients and are usually in the thoracic portion of the spinal cord, with some in the higher up in the cervical level and some lower in the lumbar level. And this was pretty much borne out by the information that we looked at, about 53% had thoracic level involvement, 25% cervical level, and looks like 5% lumbar, with about 14% we weren't able to determine from the information that we had. I'd like to spend the rest of the time talking a little bit about what we know in terms of functional outcomes. And some of the information I'm going to present represents averages. Everyone is uniquely different in terms of how their nervous system is put together, and the response to injury is going to be different. So these are average trends, and we're going to take a look at different skills that come back and see which ones are more likely to come back and which ones are less likely. But again, there's going to be differences between individual children. Dr. Knabush, who did publish a series of children with transverse myelitis, in his article made these statements. He felt that a good outcome was seen in about 40%. He defined good as essentially normal with mild urinary symptoms and or minimal sensory and motor neuron findings. He felt that about 1/3 of the patients had a fair outcome, which was mild spasticity but independent ambulation. They had urgency or the feeling that they had to avoid and or constipation, and some sensory signs. And a poor outcome was defined in his group as about 23% who were unable to walk and had severe gait problems, and no control of their bowel bladder function. So if you look at these criteria, the group that came to see us was a more involved group. Only 19% experienced a good outcome by these definitions. And this was likely a referral bias to a tertiary care center. These are pretty broad strokes in terms of outcomes, in terms of how do you define how well the individuals did. And so one of the things that we are trying to do is to be more specific in our information about how these individuals recover from their transverse myelitis. So we use different tools. But before I go on to that, this is a comparison of these three large group series about kids with transverse myelitis. And as you'll see, in all three of these reports, a normal outcome was seen in over 30%, about 30 to 40% of cases. What was defined as a, quote, good outcome, which would be some spasticity, some urgency, was seen in about 20 to 30% across these three groups. And poor outcomes were seen in about 10 to 20% of the groups. We use something called the Hughes Functional Disability Scale in tracking outcomes of our individuals with transverse myelitis, and we also use a functional outcome measure called the WeeFIM. FIM stands for Functional Independence Measure, and We stands for Pediatrics or small. The information that we have, we collected at an average of about 8 years after the acute onset of the disorder, with plus or minus 1.8 years. The Hughes Functional Disability Scale looks this way. It's a score of 0 is normal, 1 means minor symptoms but capable of manual work, 2 is able to walk more than 30 feet without assistance, 3 able to work more than 30 feet with assistance, 4 wheelchair bound, 5 requires assisted ventilation, and 6 equals death. So this is a little more specific than the previous outcomes. And this is the information that we have. If you look right after the acute attack, almost all of the individuals were at 4, which is the unable to walk and or assisted ventilation, with very few progressing to the good side, toward normal, with a population worse. The tan bars represent the follow-up measures, and you can see that the peak here shifts from 4, although there are some individuals that remain at level 4, And again, level 4 means bed-bound or wheelchair-bound. But there is a substantial number now who are at level 3, 2, 1, and 0, which would be normal. But notice that normal is a lot fewer than was reported in the previous case series. So what I'm wondering is these other case series that have gone over information collected, let's say between 1950 and 1990, whether those individuals really were normal or if they had some mild disabilities, but because of the tool that was being used to assess outcome, they were classified as being normal. So to get more detailed information, we decided to also administer the WeeFIM. And this is an 18-item instrument that measures functional performance in essential daily skills in self-care, mobility, and cognitive domains. It's designed to document functional performance in children and adolescents with either acquired or congenital disabilities. And each of these items are rated on a 1 to 7 scale, which goes from total assistance needed to perform a specific task to total independence, so requiring no assistance for specific tasks. And this is what the typical WeeFIM performance profile might look like. And it's not as complicated as it first looks, but it's sort of an interesting way to show information. It's based on the 7-point scale, going from the center of the circle being total assistance to the circumference of the circle, which would be total independence or complete independence. Then around the circumference are the 18 items that are evaluated. So we have eating, grooming, bathing, upper limb dressing, lower limb dressing, toileting, bladder management, bowel management, transfers from a bed to a chair, transfers often on a toilet, in and out of a tub, walking, doing stairs, comprehension, expression, social interaction, problem solving, and memory. So as you can see, this really covers the gamut of all those things that might be affected by individuals with an acquired lesion to the central nervous system. Then the colors here represent different time points when an individual's been evaluated. So the green might be the first evaluation, and this person in green, at the green time, eating was a level 5, and bathing over here. Maybe this one will work. Maybe this will work better. Let's see. Yeah, that's a little better. And then dressing will be like a level 4. The discharge, on discharge, they went from a level 4 for dressing to a level 6, so they got better. And then in follow-up, they went from 6 to 7. So the more you fill out the circle, the more you've approached independence for those specific tasks. So we looked at that information on the group of children that we were following with transverse myelitis. And this is our overall results in these domains. So these are the domains of self-care, sphincter control, mobility for transfers, locomotion, communication, and social cognition. And complete or modified independence was noted in 73% for self-care, and then as you follow this down, you see sphincter control was the lowest in terms of at follow-up. Only 46% were, I'm sorry, I got this backwards. 46% were independent, but it was the lowest for independence. This number actually should be 24% rather than 34%. But at follow-up, at an average of 8 years after they were diagnosed, maximal or total assistance in the group that we saw was only 24%. Locomotion, for example, here, complete or modified independence, which is basically you can walk without assistance, 67%, and maximal or total assistance only reported in 1%. So the chances that you're going to be able to be completely independent for locomotion or require moderate assistance or supervision level are pretty good, accounting for about 97% of the cases. In terms of these areas of cognition, as you would expect, that wasn't involved too much at all in these children because the transverse myelitis is a spinal cord problem rather than a disorder of the brain. So these kids pretty much were all cognitively intact and could communicate at the time of follow-up. When we broke down the scores in terms of their averages on the activities of daily living tasks, which are ADL tasks, what we noticed, and again, these are the average scores, that the children as an average were more independent and could feed themselves most easily compared to toileting, which had the lowest average. And this would make sense because it's usually the lower limbs that are involved with transverse myelitis. And the abilities to groom and to bathe, which would involve upper limb functionings, were less impaired. These are the averages for continence, and it looks like, in terms of our average numbers, that the averages for bladder function were lower than bowel functioning, with the ability to toilet in between. So bladder functioning appears to be more of a problem in children with transverse myelitis at the time of outcome assessment. Mobility, doing stairs was more difficult than walking. That makes sense. And for transfers, these are transfers in and out of a chair, on and off a toilet, in and out of a bathtub. And the more difficult the task is, the lower the average score is. So that also makes sense. So to wrap up, and in conclusion, I think that a model like the Transverse Myelitis Center at Johns Hopkins allows more rapid identification of cases of children with a rare disorder. It gives us the ability to look at a larger group of children with a rare disorder, and to make statements about how they do as a whole, and perhaps follow trends in terms of do they recover differently as we employ different kind of interventions. In our case, there was a probable bias toward more serious cases, but we're going to have to look at that more carefully. One thing that we haven't done yet, and that we'll be reporting to you in the future, is are there correlations between intervention strategies and the outcomes that we measure on tools such as the WeeFIM. WeeFIM scores, I think, are useful in this population because they do yield more details on the function of these children. So with that, thank you for your attention, and as previous speakers, I'll be happy to answer any questions that you have. Thank you very much.